And we're here. Welcome back to the Max Your T podcast. I'm Teddy Draper, a sports broadcaster in the UK. More significantly, in terms of any advice and expertise on testosterone and testosterone therapy, we're joined by Dr. Katy Draper and her husband, the central figure in this story of testosterone, Dr. Max Draper, GP, and now testosterone consultant via his own journeys and travails through low testosterone, now through therapy back to health. In part 4, we're going to look at the opportunities for people to restore their testosterone levels and the classic therapies. If you want to know more about the general story of Max or where he came to in terms of diagnosing testosterone deficiencies, then go back to the previous episode 3, and ask any questions as well in due course on the bottom of the video, and we'll get back to you in future episodes. Max, welcome along. Let's just assume then, I suppose, at this stage that someone's been diagnosed, a general practitioner agrees you've got low testosterone, we can get therapy. What happens typically in the national health system in the UK, at least?
So at that point, you would be referred either to a sort of men's health clinic. That's what I have locally to us, a sort of NHS men's health clinic. That tends to be a GP with a specialist interest, or more commonly an endocrinologist. So that's a hospital-based consultant. Endocrinologists deal with basically hormones and diabetes being one of their main areas, really.
And what's the first port of call then, Katy? If the endocrinologist typically, if they agree again that you have low testosterone, what will they issue you with? And is it dependent on your score, or is it that everyone gets it, irrelevant of how severe the deficiency is?
I'd say it's dependent on your endocrinologist rather than the patient. It seems, so the GP would pick up a low free testosterone, as we discussed in the last podcast, and they would then refer, in my practice, to an endocrinologist. The endocrinologist then, sometimes depending on other blood results, they might either order more blood tests that the GP hasn't done to look at things like your LH and FSH, which are important in telling you what their testicles to produce testosterone, to see what type of testosterone deficiency that you have.
Yeah. What those acronyms standing for again, Max or Katy?
It's luteinizing hormone and follicular stimulating hormone.
Okay.
Stand for. I think we'll discuss those in the first episode, that they're what they're responsible for. I mean, Max can tell me more. I
haven't got quite logged in my brain. Just
yeah,
I'm working on it.
When you see them, either your GP will have done this, or your endocrinologist will kind of want to get a basic idea of where's the deficiency coming from. Is it because your testicles aren't responding to the messengers from your brain, which is the LH and FSH? Or is it that part of your brain, either your hypothalamus or your anterior pituitary gland, isn't doing its job right? So basically, an endocrinologist will often be looking out for indication for needing an MRI of your brain, because there's a rare type of tumor, well, fairly rare, called a pituitary tumor that affects the signaling down to the testicles. So there's a certain picture you can look for there. Basically, the messengers from the brain are lower than they should be. Yeah. Okay. Most commonly, what I see is either, those messengers from the brain are high, meaning that your balls aren't responding well enough.
So your brain's saying, quick, produce more testosterone, and the testes aren't responding. They're
exactly
on silent.
That's what you'd call primary failure, because your testicles are the primary sort of organ involved in producing testosterone. And then you have secondary, which is where the messengers, even though you've got a low level of testosterone, the messengers from the brain aren't appropriately raised. So quite often what you do see, though, is a bit of a mix, which is where you kind of might diagnose functional, which is more that everything's just not doing its job properly. And that often is aging, lifestyle, all sorts of issues, rather than sort of in my case where I lost a testicle. A lot of guys will just develop this over years, and what you'll get is a bit of a mixed picture. And that really, basically, if you don't need to rule out a pituitary tumor or something really dodgy going on like that, which is quite rare, the treatment still is very similar. In the private world, it might slightly alter what I can do, because things like Clomid might not work if your balls aren't going to respond. But generally speaking, you've got a low testosterone. You want to get an idea that it's not something dodgy going on or very correctable. and then you're offered testosterone replacement.
And what would that typically look like, Katy, in the general practice NHS system? What would the therapy be?
So most endocrinologists start with a type of testosterone gel. So they're different brand names for it, but it's a gel that obviously contains testosterone that the man needs to rub onto a hairless area, which can be difficult in some men. And
so would they shave? I mean, I suppose it's a bit of a strange thing to talk about. I guess you'd have to shave a patch because you see that one guy on the beach, don't you? That is literally like a gorilla front and back. That maybe it's going to be difficult.
Yeah. Well, that's what Max was started on to begin with, and you used to put on the top of your thigh, didn't you?
Yeah.
And so the endocrinologist, they'll say like 1 to 4 pumps, or start on about 4 pumps depending on the strength. So they'll prescribe you the right strength that you need, and you rub it on every day, but you have to let it sink in. You've got to leave it for a period of time after you've put it on. So Max used to sit in his boxer shorts rubbing it on for like half an hour.
Beautiful.
He could put his trousers on every morning. So it's a little bit of a hassle, but it did do the job, because it was the first thing that really helped Max.
What one time a day is it, or is it double application?
Once a day usually, so in the morning, and then make sure you wash your hands. If you've got young children, or anybody, any partner, you could be worried about transference. So I think I've said before, I've had patients' wives who've grown a little patch of hair where they've like sat next to or been in bed with a husband who's had the gel on, and it's transferred to the female. So you have to be careful with that with the gel, but that's usually the initial treatment from an NHS perspective. You'll be prescribed by an endocrinologist. They'll write to your GP, and your GP will just put it on your repeat prescription, and the GP probably will do absolutely nothing else. The endocrinologist will follow you up, and they will recheck your testosterone levels at different intervals to make sure that you adjust the gel as needed.
What's the impact both in terms of testosterone levels, Max, typically, and how you feel? What's the sensation like for the gentleman taking the gel, rubbing the gel on their thighs or wherever?
Yeah, just quickly to go back to, you mentioned about, does it matter what level you start with? If you are testosterone deficient and you go on replacement, and this is what some doctors even get wrong, it's not like the dose is just a little boost. What's going to happen is when you go on any exogenous form of testosterone, so either injection, gel, cream, there's loads of different types, pellets, nasal sprays, tablets, the latter aren't really used in the UK, and they're not very good, so I wouldn't support their use anyway. But you are going to shut off your own production. So irrespective of your starting level, the dose you go on is not influenced by your starting level, because basically that starting level is going to go to 0 or very close to. Everything you're going to be getting testosterone wise is through your treatment. So I see sort of sometimes when I see the treatment, it's almost like they feel like they're just going to give them a bit of a boost, but it's like that boost is going to shut off or reduce their own production significantly.
So you're knocking down the house and rebuilding it, basically. Is that what you're saying? Yeah,
exactly. I mean, so your brain recognizes you've got testosterone in the blood, and so basically it sends less messengers to your own testicles, and there's a degree of shutdown really at a very low dose of testosterone.
What are the considerations here then, Katy? Because that's significant, isn't it? If you're basically deactivating your testes for young men in particular who may have aspirations of a family, I guess.
Absolutely. So the one thing that the endocrinologist will go through with you before they start any form of treatment is, do you want to have children? Have you had children? Have you finished your family? Because when you shut down your own production of testosterone, it means you stop producing testosterone in your testicles. And to make sperm, you need testosterone in the presence of the sperm, first of all, but it also will shut off the messages to your brain. So the LH and FSH will reduce because it thinks you've got testosterone, so it doesn't think you need to produce any, but they're also responsible for telling your testicle to produce sperm. So your sperm count will reduce on testosterone, so you can have problems with infertility. So you have to make the decision before you start. Now, it doesn't mean you can't go on testosterone replacement if you want to have a family. It's just that there are different options that you can try. So one, I think we have discussed it in a previous episode, but you can try adding in HCG at the same time to help you to still produce
What's HCG? Is that human growth hormone? Is it or what?
No, I think we
No.
said that last time.
Yeah, I know. Yeah,
I was like, yeah,
I like that
no.
one. I've got that in my brain. Yeah.
Max, you tell about HCG.
I have to try and pronounce it now. Human chorionic gonadotrophin. So
Yes.
All right, well done.
it's essentially sort of pregnancy hormone in women, and what it does in a man's body is it basically mimics, or it pretends to be, or acts on the receptors for luteinizing hormone in the testicles. So what it does is it basically, put simply, maintains some stimulation to your own testicles.
Gives them a bit of a slap.
Yeah, the benefit of it. Sorry, the benefit of it is that it's got a longer half-life than luteinizing hormone itself. So you could argue, why don't you just inject those two, FSH and LH, back into your blood? But the problem is that luteinizing hormone has a very short sort of activity spectrum. So if you were injecting it into your blood, you'd have to keep injecting it multiple times a day, whereas HCG lasts in the body for a couple of days. So you can inject 2, maybe 3 times a week if you want to split it up more. But it just allows maintenance. Basically, you're keeping the factory going.
Yeah. Katy, people don't want to do the HCG thing and perhaps they're borderline. What would you advise? What are the lifestyle things that perhaps they could look at? Or maybe natural remedies? Are there things, ashwagandha, I know is mentioned, things like that? Is there anything that could take to maybe push you into the positive zone of testosterone without threatening your fertility?
Well, there's the lifestyle changes that we've already discussed, but it also depends on. So the other thing is, if you've got very low testosterone, that can also affect your fertility.
Yeah.
So there's a balance. You need testosterone in your testicles to produce sperm. So if you've got a very low testosterone, it's the same story. So it depends on how low we're talking, but we're talking at this point, if you've been referred to an endocrinologist, that you've been diagnosed with testosterone deficiency.
Oh yeah.
Is there anything you could take, Matt, in natural remedies? Is there anything that's out there that people talk anecdotally, don't they, about this substance will boost your testosterone and that substance?
Yeah, so there's testosterone boosters that are sold loads, isn't there? So they tend to be a combination of Tongali or long jack, ashwagandha, Fedoja agrestis, vitamin D, zinc, magnesium, boron, B6. Those are the kind of commonly used ones. So the first 3, Fedoja agrestis and Tongali, that's the one that Andrew Huberman made famous by mentioning it on the Joe Rogan podcast.
Yeah.
I'm not a huge fan of them. Ashwagandha is something called an adaptogen. So rather than necessarily boosting testosterone directly, ashwagandha seems to have more of a modulating effect potentially on cortisol and sort of like a relaxation effect. So again, if you kind of reduce your stress, improve your sleep, that can maybe have a knock-on effect on your testosterone. I believe that's how it works. Anyway, it's not sort of my.
So if you're a 7, if you're a 7, could Tongarelli get you up to an 8, 9 feasibly, or is it more that's not going to work the same way that testosterone therapy would in terms of an actual gel or a injection, which we'll talk about in a second?
I mean, yeah, that's night and day. Good TRT compared to the sort of herbal or those approaches. I would say that Tongarelli, it was kind of advertised to say that it boosted your testosterone by 200, which in English speak is like 7 or 8, I think. Quite significant. But a lot of the research in Tongarelli was in hypogonadal men, and also it's not long-lasting research.
What's a hypogonadal men? Is that with less test?
So a lot of it was sort of the research is a bit
less gonads. Has it been hypo? Is that?
Yeah, hypogonadal just means that you've got low testosterone. It's just a medical terminology.
Okay.
So my problem with it is that it's sold to a lot of young men for like a T booster, but a lot of the research was done in men who were low testosterone to begin with. So that's sort of partly a marketing ploy.
So it's not a preemptive thing for young men potentially.
Oh yeah, I wouldn't necessarily say. I don't think, if you get your lifestyle and everything else in thing, I'm not a fan of T boosters as such. Ashwagandha seems to be a decent remedy for some things as well, stress reduction, that sort of thing. But the problem with Tongarelli and Fedoja agrestis is there's not a lot of long-term data on them. And in terms of things like toxicity, safety, they don't have to go through the same rigmarole that medication do. In order to get a medication approved, you have to go through, steps of safety data and things like that. A lot of these herbal remedies don't have to do that.
Yeah.
Certainly vitamin D, magnesium, boron, B6, so vitamin B6.
Zinc.
And zinc and selenium as well. those seem to potentially have a positive effect. But again, we're talking about what level are you at and what symptoms have you got. I'm not convinced if you feel like rubbish and you've got a low serum testosterone that any of these are going to make a dramatic enough shift in the needle in order for you to feel great again, you know? And again, it goes back to that nuance of why are you there? What's led you to having a low testosterone level? Is it correctable? Is it correctable easily? You know, vitamin D is a big one because, you know, men with a low vitamin D, there is a correlation with testosterone levels. So that's a simple, easy one to consider. But
that's a common deficiency as well, isn't it? Vitamin D in the UK, certainly, because we don't have much sunshine, and even when it is sunny, we tend to sit indoors on laptops.
Yeah, and again, the levels recommended in terms of the supplementation can be pretty rubbish. You know, it's sort of like 400 IUs a day, which is a very, you know, small smidgen of vitamin D. So I'm not a massive fan of that.
You're better off getting sunshine if you can, particularly in the summer months. I mean, it's also, you know, on my podcast, Sport and Life, had a conversation around melanoma recently. So it's a kind of, like riding that horse sensibly, I guess, is the key with sunshine.
Balancing act, isn't it, really? Yeah, like everything, balancing act. But
I mean, you probably only need about 2 minutes in the sun to get your vitamin D, don't you, with that skin?
Yeah. I didn't need to look at it and I'm burnt.
Yeah. That's interesting. Yeah. So I mean, we got those options, but I think what you're saying is that therapy is probably the best way to go if it's an acute issue. And Katy, the gel, Max moved on from the gel to injections. Why was that? What was the thinking between you two at that point?
Well, at the point, so when Max started the gel, it really did help. It did make a huge difference, and it was like that light bulb moment of, oh my God, it is low testosterone all along, wasn't it? And it from there sparked all of Max's extensive research. So the reason Max changed to injections was from his own research of wanting to use the gold standard treatment for his testosterone and to, you know, not have the hassles of the gel, I think was part of it, but also to be able to microdose testosterone, because that's what Max wanted to do. For everybody else, obviously the treatment is individual, and Max will go into it in more detail, but the next thing they'll offer after a gel is a type of injection. So there's 2 types of injection on the NHS. One that's called Testosterone, which is 4 different esters of testosterone. So there's 1 short-acting testosterone, 2 medium-acting, and 1 long-acting testosterone. So, and you inject that every 2 to 3 weeks. And then the next option is a much longer acting testosterone that you can use, which is called Nebido. And that one you inject every 3 months, is that one?
10 to 14 weeks.
10 to 14 weeks, there you go. So depending on the person, what they want to do, how they feel on the treatment, what their testosterone levels are like when they start the treatment, it's very individual. And I think, you know, if you need an endocrinologist who is going to spend the time treating you as an individual, and I think that's why Max in the end decided to do his own research, and when he found Alpha Genix, because he wanted to be on gold standard treatment, which isn't offered on the NHS.
And when you request the gel, Max, on the NHS, can you push for injections then if you think there's something that the gel isn't working as well as it could? Or will a GP be reluctant to progress you, or an endocrinologist? How does that work?
I think if you're on the gel, a lot of the times the gel is like a trial of treatment and then switch to the injections when you've sort of settled and you know that you're feeling better with the gel.
Yeah.
Tends to be what we see is you start with the gel. Does it help? Yes. Then you go on to the injections, simply because the injections for the average person is better for compliance as well. You know, it's a less frequent administration because that gel, you need to apply it every day. It needs to be part of your routine. Some would argue you need to apply it twice a day if you look at the half-lives, but that's just my opinion from research. So the injections basically, let's put it this way, it's a cheap way of giving someone testosterone that ensures their compliance is reasonable as well. Because if you don't comply with the treatment, you're going to actually potentially make yourself worse.
But what are you doing? You're injecting daily, is that right?
I'm injecting testosterone cypionate, which is, so every testosterone is combined with something called an ester. So cypionate is just the ester. That's in order for the testosterone to stick around in the blood for a while. like luteinizing hormone, if you injected pure testosterone, it's in and out of the body really quickly because it gets metabolized very quickly.
Okay.
So you need to attach it to something called an ester, which basically and each ester has a different half-life, which means it stays in the blood for.
What does ester stand for? It's not related to Esther Ranson, is it?
I hope not. Otherwise, I'm injecting her every day.
Yeah.
But so ester is just a medical term, so it's just what it attaches to. So cypionate is the form of testosterone I use. Essentially, basically, from my own research, good TRT, you want a steady state of testosterone in the blood, and you want it to be reliable day to day. With Nebido, which is this big bolus dose every sort of 10 to 14 weeks, two major issues for me. That is a roller coaster, up and down. Secondly, there's not much you can adjust. So you can either take it every 10
So what happens? You get like a huge spike of testosterone that it just gradually wears out throughout the course of the till the next injection, and presumably that can kind of swing your mood and your state.
Yeah, well, it's even more significant than that, because when that testosterone sort of bolus gets injected, you can look at this online. People can Google Nebido dose graph, and it is sort of like an up and down pattern. The issue as well is that when you get those spikes, there's a lot of other processes that go on in the body when you peak and trough your hormone levels. And that includes, the testosterone changing into, like I said, DHT, estrogen. It includes other processes that are reliant on testosterone being altered at a varying rate all the time. So we know that, generally speaking, symptoms are better if you have a steady state as well. So it's kind of like you don't need to inject cypionate daily. That's just a personal preference, just because I'm a bit OTT and I just, I don't mind injecting.
But is there downsides to it, to injecting it regularly, or does it not matter?
It's just I suppose people would argue it's the hassle, really.
And landing sites in the body, if you don't like needles, is it, veins and things like that? Is it easy to do and administer every day? You've got a finite amount of spots you can inject to.
It doesn't go into a vein, so so it's either subcut or an intermuscular injection, and they're very tiny little needles. I do most of his injections.
Yeah.
When your muscles relax. So when Max is doing it himself, it's just it hurts him more. So often I do it, and literally it's 2-second job.
It's subcut is subcutaneous fat. Is it? Tummy.
That's into your belly fat.
That's in your belly fat, and then intermuscular. Normally Max injects, or I inject into his muscle here.
And Katy, is that possible to get that type of treatment on the NHS, or is that something that people would have to, if they wanted to inject daily, go through private?
You'd have to ask your endocrinologist, but I know that, you'd have to go private probably, because they don't do cypionate on the NHS, do they? Because it's expensive.
It's highly unlikely. I think it's highly unlikely. The other thing that we use is Sustanon, but microdosed. So again, you're taking the dose, but you're splitting it up through the week. A lot of my guys aren't on daily injections because that is probably overkill. And there are other factors that I look at when I'm dosing people, as in telling them how frequently to dose. For example, your SHBG has to be factored into it as well. So there is a bit of nuance to it. But
also your lifestyle preferences as well, presumably. If you're someone that's not particularly disciplined or good at remembering things like that, it could be tricky.
100%. A lot of the time is guys just, I want to inject twice a week, let's say, and because it's a hassle and everything like that. So it's very individualized. You've got to look at blood markers as well as the person, and that includes the treatment threshold as well. I don't have a target level that I want you to get to. I have a rough idea where you might feel best, but it's very individualized.
Yeah. And we getting to a score then, and looking at that score and then plateauing? Is that the goal, Katy, for an endocrinologist? Would they say, let's get you to 15 and then work out what the dose should be to keep you there?
Kind of, but I think I don't know what the endocrinologists work towards. I think they just work towards it being within the normal range, and I don't think they particularly focus. Am I wrong? Particularly focus on what the level is, as long as it's within the normal range. Especially with Max's experience. So it might be like 14, and they might think that that's okay, but that actually is not what you would call an optimal level of testosterone. So if you talking to a specialist like this guy, he'll tell you that really you want people in their 20s to be at an optimal level, but again, it depends on how the person feels on the dose. So if somebody feels completely better and their testosterone levels are, you know, wherever they are, then that's fine, isn't it? That must be what they need.
Yeah,
to the right level for them.
Yeah, how important is that to Max? Is that sort of subjective, qualitative factor, self-reporting of how you feel? I mean, do people, you know, is it worth journaling it, how you feel on certain levels, etc., just so you've got a reference point?
I would say, and this is sort of my experience speaking to other or observing other TRT doctors, is that the blood test is basically making sure we're not taking any years off at the end of your life. What you tell me is whether you're on the right dose or not. Okay. I can't take a biopsy of your body to say how much testosterone your androgen receptors will be happy with. You have to tell me how you're feeling. Guys can go too high or they can go too low.
Yeah. So honesty is important, isn't it, in the process?
Yeah. You know, you've got to judge the symptoms at the start, and then how do you feel now? The blood test is not the guideline that I would say. If I get your blood test back, I'm really just making sure you're not too high, to be honest. You know, and too high is a debatable area, but really it's how do you feel? Is it helping how you feel? Because I don't know how much you'll need. I don't know what level you'll feel best at.
Can it be addictive though, Katy? I mean, it's quite an intoxicating substance. You remember being a 15-year-old boy, it's like literally you feel like you're flying, don't you? I mean, it's a strange sentiment, Katy. Is that something I guess doctors have to worry about? Is that someone wants more and more and more just to feel more bulletproof?
I think it can have negative effects also in too higher doses. So yeah, I mean, the thing is, you've got people like Max who've gone from feeling so unwell to something that makes them feel better. So is that going to be something that he's going to become obsessed with, or might be an addictive thing? Maybe, but also Max knows when he goes slightly high and he's had to adjust his dose down because he gets some negative.
What happens?
Well, I would say he feels probably more irritable.
Roid rage.
Not, I wouldn't say, yeah, maybe a little bit more cross at things, but just more irritability and inability to settle is what I would describe it as, when he knows that things are not where they should be, and that's really unpleasant. So actually, I think the side effects of it being too high is quite unpleasant as well. So that's why. Can it be addictive? Depends what you're using it for. If you're using it to build muscles in the gym, probably yes. I mean, we know that people also abuse testosterone. So, you know, yes.
And again,
but if you're using it because you've been really unwell and you have a testosterone deficiency, it is, you know, if you're sensible and you're recognizing the symptoms of it being not right, and you've got a good specialist who's helping you to like adjust your dose, then you're all right. That's what I would say.
And Katy, in a previous episode, we spoke about the importance of a partner or other people in your life maybe detecting any kind of swings of its low testosterone, the mood issues and kind of changes in a person. But I guess if you're going too high at the other end, you have to kind of say to them, because if you got testosterone kind of you know, I don't know, rage or just focus, it could be something that perhaps you're not aware of. So maybe it's up to the wife or daughter or son or whoever to sort of pick up on it.
Yeah, well, I think so, but it wasn't necessarily the testosterone itself that gave Max the worst side effects. It was HCG, and Max doesn't tolerate HCG very well. Different for different people, but because well, in my head, the way that I see it with the HCG, because it is making you produce testosterone in your testicles, it's giving you little spikes in testosterone, right? And so Max was taking it from a fertility perspective. And he just doesn't tolerate it. I think those little spikes, I think you're very sensitive, like to your levels, and those spikes just make him an arsehole, really.
Oh, is that what you mean? You say tolerate it? What was it? Just irritability?
Yeah, just irritable, grumpy.
There's receptors as well. This is the thing, is that what people don't realize is that the body is very complicated, and in terms of things like HCG, there probably is receptors directly for it in the brain, or at least because it's mimicking luteinizing hormone, it has effects not just in the balls. Most men will feel either nothing with HCG, as in it doesn't make them feel worse or any better, it's just there to keep the lights on in the factory. Some guys will feel irritable, anxious, on edge with it, and that's a lower percentage of blokes, but that's a recognised issue with it. I'm not sure whether it is due to peaks and troughs and things like that, or whether it is actually just genuinely the HCG itself. But it's quite interesting. If I was to describe what a lot of people report if their TRT dose is too high, there is a little bit of irritability there. A lot of it is almost like a tense feeling, because there is a balance with your hormones in terms.
Too much energy.
Well, almost just too much. A lot of people would describe almost like a tense chest feeling, like they want to go out and they have to, it's almost like a drive. And that is more of an imbalance rather than directly saying that testosterone causes irritability and things like that. That's more of so some guys I've had have got levels back on a reasonable dose, but because everyone's different, that reasonable dose that I started them on, they'll come back at like total 55, whereas another guy might come back at 15. And that's just the individuality there. It's how much it can vary is huge.
Final thought, because I think this is an important point that we brought up actually, was the sort of finality of it. With you that HCG is something you can try and counteract the debilitating effects on your fertility. But this is, Katy, I suppose, a big decision to make, isn't it? That once you go on to hormone replacement therapy, it is, Max is in his mid-30s, but this is something he's going to have to do until you're burying him, or, realistically, he's not going to bury you. not looking at the family history anyway.
Yeah. What's the question?
No, just that it's not a sentence, but it's a lifetime commitment. So once you make that decision to go on to inject testosterone, that's kind of it.
Yeah, absolutely. So yeah, it's not something that he'll ever come off, because we know that his body's never going to be able to produce the level that he needs. So in his individual circumstance, this is his life, that he'll always inject. I mean, it'll do him some favors in the future, because he won't hit the andropause, because he'll be injecting testosterone. He also has the ability to change his levels when you won't. I mean, you're injecting it, so he doesn't produce any of his own, but he's got the ability to monitor it for his whole life, which is good. And he won't be on HCG for life. That's a job.
keep churning them out till his 70s. Yeah, the kids.
Yeah. If that's something that happens, then great. But if not, it's not going to be something that Max personally would continue with. Some men take HCG because they don't like the idea that you can get testicular shrinkage with testosterone. So they prefer to take it to keep the lights on in the factory, as Max says.
Look good on the beach in your speedos.
Rather than the fertility, but there are other options for fertility, and that is depending on what the cause is, or the reason that you have low testosterone, whether it is an issue with the signaling in your brain, or whether it's an issue with your testicles themselves. You can take medication that boosts your own testosterone rather than injecting testosterone. So those medications that Max might talk about on another one that you don't like as much, but they can be used for fertility, like Clomid for men, which helps you boost your own rather than injecting testosterone directly.
Is that a tablet?
No, Clomid's a tablet.
Yeah.
Okay.
So there are other options for fertility depending on the person.
Absolutely. Well, Katy, Max, brilliant to have you on the podcast again. And again, people put questions below. And Katy, Max_your_T is the Instagram account, isn't it? Where we put lots of facts and stats up there, which people can respond to in the comments as well, which we'll read, and any queries that people have about their individual circumstances, or maybe a friend in their life who they're concerned about regarding possible low T.
Yeah.
Good stuff. Speak soon, guys. Take care.
Thanks, Teddy.
Bye.